Dr. Haley, I'm sorry to interrupt, but I just need to check if the virtual audience can hear the audio. I'm unable to hear the audio.
Same here, Robin.
Thanks, Robin.
Thank you.
Okay.
If all else fails, log off, log on.
That's right. Just have to call Robin. Let's see. Because it all looks good on our end.
Oh, now we can hear, or at least I
Oh, can you hear me now?
Yes. Yes, it looks
All right,
like
great.
I can as well. Thank you.
All right.
I don't know what
All right.
I don't know what happened differently, but okay, great. Well, thank you for speaking up. Sorry, if you have any other questions or issues, please speak up. So hemophilia treatment centers, both have been shown to decrease mortality and then also things like hospitalization. So this was another study and they found that people with hemophilia treated at an HTC were 50% less likely to experience a bleeding event requiring hospitalization than those who weren't. Here at OHSU, we have recently changed our name from the Hemophilia Center to the Hemostasis and Thrombosis Center, mostly to reflect that we take care of people with von Willebrand's disease, platelet disorders, inherited clotting disorders like protein C deficiency, and we just wanted to be a little bit more inclusive. And we are a lifespan program, so we are like academically housed within the Department of Pediatrics, but we see patients all throughout the lifespan. And we have a really big catchment area, like most people that work at OHSU, and we see patients in Oregon, Southwest Washington, Northern California, sometimes Idaho, and sometimes Alaska, depending upon their availability of hematologists. We're the only hemophilia treatment center in the state of Oregon, and the next closest is either Seattle or Spokane. And so we often get people coming from all over as shown in this map. So this is like kind of a weird stretched map, but it has Washington, Oregon, and Idaho, and a little bit of California, and just shows where our patients are coming. So this is about 1,400 patients, and then the heat map just shows the distribution of these patients. So a lot of patients along the I-5 corridor, but we certainly have a few patients out in the middle of Eastern Oregon. Yeah.
The work that goes into generating that heat map for you.
Yeah, that's awesome.
Yeah.
I want that.
Yeah. Really great question. We have this great data analyst, Amit, and I could definitely connect you. He works at he's like housed within the business, and I don't remember what it's called, but yeah, I can connect you. It took him a long time to figure out how to do this, but now he knows. Yeah, let me know. And yeah, it was really helpful for us because as I'll talk about in a little bit, it helps us think about like, okay, if somebody's over here in Harney County, you know, there's only 2 people over there, but if one person bleeds and they don't have access to their medication, that's a really big deal and a high problem for that patient, but also high cost to the healthcare system. And then this also helps us think about where to do outreach clinics. This is kind of the general group of our team. So we have a large administrative team, a ton of managed care experts to help us think about authorization for some really expensive medications. Our clinical team with our nurse practitioner, hematologist, social worker, genetic counselor, physical therapist, education specialist. And then we have our own pharmacy within our team, and that also requires a ton of work with compliance with managed care. And that is a 340B pharmacy, which allows us to sell drugs at a reduced rate, and then all proceeds from that come back to fund our program and to serve the patients we take care of. As of 2024, we had a little less than 1,900 unique patients with a diagnosed bleeding or clotting disorder served at the HTC. And that doesn't include all of our patients that we saw for a consult to rule out bleeding disorder or in the workup phase. The majority of those were hemophilia A, and then a smaller portion of hemophilia B, and then 360 were von Willebrand's disease. That is less than we should be seeing with von Willebrand's disease. Von Willebrand's disease is the most common bleeding disorder, affecting up to 1% of the population. So the symptoms, though, tend to be more mild in lots of cases. And so we don't see those patients as much, but it's a project we're working on. And then we see platelet disorders, other factor deficiencies, things like that. Okay, so that's who we are. So now get ready, coagulation cascade. It's gonna be fine. Don't worry. So just to review, so we know where hemophilia is sitting in this, we have some sort of endothelial injury, and then that causes exposure of extracellular matrix proteins, release of von Willebrand factor. That allows platelets to adhere, and then platelets get activated, send out signals, and then platelets aggregate together. As that's happening, coagulation cascade, we have the activation of the clotting factors. This is, as we now know, a more simultaneous event and ultimately leading to both a thrombin burst, which is really important to keep things going, and then generation of fibrin, and then your fibrin forms your stable clot. And then what's often left out of coagulation cascades are the antifibrinolytics, but as I'll talk about in a little bit, these are getting a little more attention, becoming more in vogue. And so we have our antithrombin, TFPI, protein C, protein S that are turning off the coagulation cascade. That was it. Did it. Okay. So hemophilia is an X-linked recessive disorder, but about a third of patients, there's no family history and it's a spontaneous de novo mutation. Hemophilia A is factor VIII deficiency, affects about 1 in 5,600 male births. There's been a lot of work in the last 5 years to identify people with 2 X chromosomes who have hemophilia. And what we have learned over the last few years is that people who carry the hemophilia gene have more bleeding symptoms than those who do not. So even if you have a normal factor level, but you carry the hemophilia gene, you still report more bleeding. And then we're finding when we actually test factor levels on people who are obligate carriers, so daughters of men with hemophilia, that it's not uncommon that their factor level might be 47%, might be 51%, so right on the border of normal, and that those patients also report bleeding. The statistics haven't caught up, and so the CDC still will report data as male births, and they don't pay attention to people with 2 X chromosomes. Hemophilia B is much less common, affects about 1 in 19,000 male births. This is just the data based on severity, and so we see much more severe hemophilia for hemophilia A than for hemophilia B, and then mild is more common for hemophilia A than moderate. So speaking of those classifications, the factor levels in hemophilia tend to correlate fairly well with bleeding symptoms. So if you have factor levels less than 1% and normal is around 50 to 100%, that's severe hemophilia. We see spontaneous bleeding into joints, muscles, bleeding with trauma surgery, mucocutaneous bleeding. 1 to 5% is moderate hemophilia. You can still see some spontaneous bleeding, but it's less common than with severe. And then for mild, it's very rare to see spontaneous bleeding, but certainly see bleeding with trauma and surgery. And then if you have greater than 40% factor VIII plus the hemophilia gene plus bleeding, the term we use is symptomatic carrier. So just in general for symptoms, nosebleeds can be frequent and prolonged. They often kind of get put to the side because they aren't sometimes as big of a deal as what's going to happen in your joints or muscles. But patients will report that these interrupt school or work, can be really disruptive. I'm a pediatric provider, and so parents will report my kid with hemophilia goes to daycare and they have 20-minute nosebleeds, and the daycare won't keep them there because of that. And so they send them home because there's blood all over. So they can be really challenging. Oral bleeding, patients will have often recurrent gum bleeding, and then that results in them decreasing desire to perform oral health, and they have more gum bleeding. We get in this cycle. And then even minor dental procedures can become a life-threatening event if they do a nerve block, and then you get a big hematoma that goes down into the space in your airway, and that can become a big problem. Muscle bleeding certainly can inhibit function and movement, can cause nerve injury, compartment syndrome, myositis ossificans, pseudotumor infection, all sorts of things. Intracranial bleeding, rarely spontaneous, although it can occur highest in severe bleeding disorders like severe hemophilia and extremes of age, and then certainly trauma-induced. And we always say if somebody comes in with hemophilia and you're concerned about a head injury, just give them their factor and then do the CT scan or whatever you're going to do. In babies with hemophilia, the rate of intracranial hemorrhage is about 40 to 80 times higher than in babies without bleeding disorders. And then for adults, intracranial hemorrhage occurs about 10 to 20 times more often than in patients without bleeding disorder. And the mortality is up to 20%. We do a lot of work coordinating for babies who are going to be born with hemophilia and just make a big plan about like trying to manage to avoid like forceps and things like that. And then joint bleeding, which I'll spend a little bit more time talking about, can inhibit function and movement and certainly cause long-term joint damage. So this is some data from the CDC. There's a large registry for bleeding disorders that we participate in. And this is looking specifically at hemophilia A. The data is really similar for hemophilia B. And this is looking at about a little over 7,000 male participants with hemophilia A. And the top bar is mild, the middle bar is moderate, and then the last is severe. And you can see that majority of patients with severe hemophilia will have a joint bleed at some point in their life. And then same with moderate, and then at least half of patients with mild. I think sometimes the patients with mild get kind of forgotten, but they certainly are experiencing joint bleeding. And my experience with patients with mild is actually they're more challenging than severe because they have bleeding less frequently, so they're not as quick to recognize the symptoms and their treatment often gets delayed. I'll go through a little bit more about hemarthrosis in a little bit, but I want to talk a little bit about inhibitors. So factor inhibitors are antibodies with specificity either against factor 8 or 9, depending upon if you have hemophilia A or B. They're more common in hemophilia A, occur in about 15 to 30% of people, and they're rarely seen in hemophilia B. It's usually something we see in kids that develop, and typically by 50 exposure days to product. However, there's some new products that I'll talk about that are non-factor products that we're using really commonly. And so patients maybe don't see as much factor product. And so we're seeing inhibitors develop later. The risk factors for inhibitors are certain factor mutations, family history of inhibitor, stress at the time of the factor administration. And these are things that make factor 8 or 9 ineffective. And so we have to use bypassing agents like recombinant factor 7 or FIBA. But this, before, as I'll talk about in a minute, a medication came out that will really treat patients with factor inhibitors. I used to be able to tell you like the name and MRN of everybody with inhibitor because they were in the hospital so often and they were bleeding so much. These are the kids that like had like recurrent compartment syndrome and just like tons of bleeding. So for treatment, generally we give them what they're missing. And it's like I always say to the fellows when they're on call that like these are the easiest calls. You just give them what they're missing and then like ask questions later. And that's usually just a good way to go. For factor 8 and 9, we have concentrates that are given intravenously and they're either plasma derived or recombinant. There's a long history of hemophilia treatment that I'm not going to go into too much today, but historically, patients with hemophilia initially were given either whole blood or plasma, and then eventually cryoprecipitate. And in the 80s and 90s, we didn't know about HIV and hepatitis. And so a lot of patients with hemophilia were infected, and then a large population died secondary to infection. And then eventually the factor 8 and 9 gene were identified, and we were able to make recombinant factor. However, now we have very safe plasma-derived products, and for certain patients, those are the right option. There are both standard half-life products and extended half-life products, and typically factor is dosed to correct levels to 100% in the event of a bleeding event or for surgical procedures, and then the duration is situation dependent. Factor products are not widely available, but we always have factor as the Hemophilia Treatment Center in the state. But we keep track kind of what hospitals have factor, and some will have like random things, and you're like, oh, I haven't seen that factor product since like 1995. And so we will kind of have an idea of where the factor is in the state. But our recommendation is for every patient to have at least 2 life-saving doses of factor on hand at any time that they can then bring to whatever medical facility they are going to at least get their first dose while we figure out transport to OHSU if we need to. And then the majority of our patients with severe factor deficiency and a lot of patients with moderate know how to infuse their own factor. And so they will put on a tourniquet and place a butterfly and infuse the factor themselves or their parents for the pediatric patients. For adjuncts to factor, we will often use antifibrinolytics, so TXA or aminocaproic acid, and these are very frequently used by our team. And then DDAVP or desmopressin can be utilized in mild hemophilia A. It works by releasing von Willebrand factor from your storage molecules, which are just like one more like nerdy hematology thing, are your Weibel Pilati bodies in your endothelial cells. I always say if you're ever like feeling sad, you just say like Weibel Pilati bodies over and over again, and you will never be sad again. So von Willebrand factor gets released, and then that results in increased circulating factor VIII. This isn't a great option for long-term use in patients with hemophilia because you develop tachyphylaxis just because you only have so much stored von Willebrand factor. And then because DDAVP also affects your sodium and water balance, you can get hyponatremia. Our treatment is either on demand or prophylaxis. So on demand in response to injury or a bleeding event, peri-procedurally. And then prophylactic therapy is the standard of care for severe hemophilia, and it's very commonly used in moderate hemophilia, and we have both factor and non-factor products. So prophylaxis became the standard of care after this study, which was, it's called the Joint Outcomes Study in our world, but I always get confused when I'm like, the Joint Commission, what is but Joint Outcome Study in hemophilia. This was a big study that looked at prophylaxis versus on-demand treatment. And they had 65 males that were, younger than 30 months who were randomly assigned to either receive prophylactic infusions at a regular interval or episodic therapy at the time of a joint hemorrhage. And the primary outcome was incidence of bone or cartilage damage as detected in index joints, the ankles, knees, elbows by either X-ray or MRI, which was kind of like in hemophilia, we tend to just use physical exam and not imaging studies. So this was like very specifically trying to see, is there any change on imaging? And at 6 years of age, these children were evaluated, and 93% of those in the prophylaxis group had normal joints on MRI, but 55% of those on episodic therapy had normal joints. So the relative risk of MRI detected joint damage with episodic therapy as compared to prophylaxis was 6.1. And so this really made it very standard for people to be placed on prophylactic therapy. In this study, they generally kept factor VIII levels and 9 levels, at 1% or greater, but it was just the goal was to get them to 1% because we know that people with moderate tend not to have spontaneous joint bleeding. And so it's like, let's just get them into that 1% range. In the prophylaxis group, 2 patients developed a factor VIII inhibitor, 0 patients in episodic group developed an inhibitor. So it's something we have to think about with these lots of exposures at an early age to factor. Are we increasing their risk of developing joint hemorrhages inhibitors? And then the cost of factor prophylaxis was about $300,000 per year. So not a small amount. But overall, this is looking at both joint hemorrhages and other hemorrhages. So, and at different ages over the time of the study. And so the first kind of bar is prophylaxis joint hemorrhage rate. And then the next one is prophylaxis with other hemorrhages. And then the yellow colors are episodic therapy with joint and other hemorrhages. So both joint hemorrhages and other hemorrhages, those nosebleeds, those muscle bleeds, everything else were decreased with prophylactic therapy. And so the general consensus was that this is going to ultimately be the right thing to do for patients. Generally, though, at the time we were, and still even today, we're giving prophylaxis as intravenous infusions, and it's just periodically through the week. So this is kind of an example of what we might see. So where you give a dose on Monday, your levels get up nice and high, and then over the next few days, they go down just with the metabolism of the drug. You give another dose on Thursday, Sunday. So you kind of get these peaks and troughs, but the goal is always to keep you above that 1% level. But I always think about what's happening on these other days that's going to increase the risk of bleeding. And we do our best to time. And so we'll say, okay, do it, before you go skateboarding, give another dose of factor before you do that. But then you're just giving a ton of factor. And so we'll try to, for our patients who are like out playing sports or doing other things, to make sure they time according to their,
counsel patients not to do certain sports?
Yeah, really good question. Do we counsel patients not to do certain sports? So we really try to discourage the high contact sports, so football, lacrosse, ice hockey. But there is always like a negotiation phase. And I think, we really try to encourage physical activity to help them be stronger and their joints and muscles be stronger, but then try to dissuade from certain activities. I always try to encourage swimming. I was a swimmer and like, it's like not cool. And they're always like, no, that is not the sport I want to do. They always want to play football. There is some guidelines from the National Hemophilia Foundation, which is now the National Bleeding Disorder Foundation. It's called Playing It Safe, which will give like kind of like guidance on what sports are like highest risk versus lowest risk. And we try to just like give that to them. A lot of patients will say, I want to play this sport. And then we try to figure out, okay, how are we going to make it as safe as possible? So do you, what are your practices like versus what is your games are like? And then try to like dose their factor accordingly. I always have like a challenge because I'm like, oh, also like you're playing this sport and it's like now $500,000 a year to pay for your medications. Is that like, is that okay? I don't know. I have that moral quandary a lot. So yeah. Newer products that we have longer half-lives, and that allows for less frequent infusions and higher troughs. So that sometimes can be a way to get around that question of like, can they play this sport? So that, as I mentioned, there's some newer medications that are non-factor medications that have really changed the way we treat hemophilia prophylaxis. So emicizumab is a bispecific antibody for activated factor 9 and for factor 10. So what factor 8 normally does is bring activated 9 and 10 together. And so this is just replacing that function. Instead of giving intravenously, it's given subcutaneously, so a much easier option for patients. And then it's used for only hemophilia A, but it can be used for patients with and without inhibitors. And this was approved in 2017 for patients with inhibitors and then 2018 for patients without. And I would say the uptick of this medication was like most of our patients switched over to emicizumab. So this is a very commonly used medication. Unfortunately, it interferes with like all of our standard clotting assays, like the PTT and the factor 8 levels that we do here at OHSU. So it makes it hard sometimes to manage for like surgeries and things like that. If you're trying to figure out, okay, if I gave this factor 8, what's going to be the effect? And we can't measure the effect of emicizumab in the lab. So when they were doing the research studies, they did thrombin generation assays, but you can't really measure otherwise emicizumab. But it likely provides the equivalence of about 20 to 30% factor 8 activity, but it keeps you at a steady state. So instead of your peaks and troughs, you're just constantly at 20 to 30%. So it's a little bit better. This is just a few different studies looking at efficacy. And so in this first one, as this bar graph, they looked at children and adults, spontaneous bleeding and traumatic bleeding, and definitely see, this is like very typical of children of not very often have spontaneous bleeding, but like lots of trauma. And the opposite is true for adults, but still the rate of bleeding is pretty low. And then they looked at just comparing on-demand factor 8 versus emicizumab, and then factor 8 prophylaxis versus emicizumab, and found that emicizumab was superior for preventing bleeding. There's some other non-factor, there's one more coagulation cascade. Non-factor hemophilia prophylaxis. Otherwise, there's a couple drugs. So marstezumab and concizumab, terrible names. Marstezumab was approved by the FDA in October, and then concizumab was just approved like 2 days ago. And these are anti-TFPI. So TFPI is the anticoagulant that will shut down your tissue factor 7 pathway. And these are antibodies to that molecule, which then you could think, okay, this is potentially, I made these slides right before the concizumab was approved, so it just got approved. Increased risk of thrombosis with these medications because of that in the clinical trials for concizumab, and then they adjusted the dose and they didn't see the thrombosis. But it makes us think about for like maybe our older patients or elderly patients, this wouldn't be the right drug for them because of that risk of thrombosis. The advantage, of course, is it's given subcutaneously, and then these both could be given for hemophilia A or B. Yeah.
How frequent is the dosing?
Yeah, good question. For martezumab, it's every 2 weeks, and then concizumab is every day. So that is a little more challenging. I don't know why you would choose that one, but I'm sure that somebody will tell you why. And then fitusiran is a small interfering RNA that inhibits antithrombin. It's not FDA approved yet, but it will be. Yeah.
But do they have to go somewhere to get these, or can they?
These ones can be given at home. Yeah. Yep. And then all of these can be used for either hemophilia A or B. This is different than, right, their factor prophylaxis where they're giving it IV. Again, most patients who are on factor prophylaxis, they're doing it themselves or their parent if they're little, but we start teaching kids how to give their own factor somewhere around 7 or so years of age. We have a bleeding disorder camp that's in the summer. It's a week-long camp. It's super fun. It's like totally insane. But one part of that camp is for kids to be able to learn how to do their own factor infusion. So we have a table set up. Everybody's got their little tourniquets on. They're putting a little butterfly in their vein. It's like a very weird thing to walk into if you've never been to hemophilia camp. But it's a really big thing for these patients so that they can be really independent. So they don't have to come to clinic. They don't have to go to the emergency room. They can go camping. They can go out in the world and get their medications as needed. For patients with inhibitors, as I said, for treating bleeding, we can't use factor 8 or 9 in most circumstances. Sometimes when you have a little inhibitor, you can, but usually you have to use a bypassing agent, either a recombinant factor 7A product or plasma-derived, which is factor 8 inhibitor bypassing agent, or FIBA. And then for prophylaxis, we can use a bypassing agent, emicizumab for hemophilia A, and then likely marstacimab and cotizumab for hemophilia A or B, although the FDA indications haven't included those yet because the studies aren't quite done. And then we try to get rid of the inhibitor by doing immune tolerance induction, which is just like a ton of factor 8 to try to like convince the immune system that it's normal. And that can take years of daily high dose factor 8 and is successful in about 2/3 of cases. So thinking about prophylaxis, we've definitely shifted our paradigm for how we do this. And historically, we've had factor levels of 1% as our goal, but we've really decided that this is inadequate to prevent bleeding. And as I said, our joint outcome study, prophylactic factor infusions resulted in less joint damage than episodic infusions, but there was still joint bleeds happening. And then, as we said, the goal has historically been to keep trough levels in the moderate hemophilia range of 1 to 5%. But there's been a few different studies that have looked at, is that adequate? And so there's a pharmacokinetic study looking at extended half-life for EHL factor 8 products. And for patients who had levels 1 to 3%, 42% had no bleeding event. But for people who had 8 to 12% factor levels, 62% had no bleeding events. And then a retrospective study looking at joint bleeding and factor levels showed an 18% reduction in joint bleed frequency for every 1% in your factor activity with prophylaxis. And then this other large study of nearly 5,000 patients predicted the number of joint bleedings approached 0 when you kept your factor levels at 30%. That's hard to do with our current state. This is kind of looking just like summarizing those studies. And so historically, we've tried to keep your levels at 1%, and then more recently 3 to 5%. And now lots of studies suggest maybe we should keep you between 15 to 50%, and that would provide a near zero joint bleed rate. Again, that could require infusing factor really frequently, and even emicizumab wouldn't get you to that level. Despite all this work to try to get people on their prophylaxis and try to keep them at a good level, bleeding still happens. And that may be because prophylactic treatment isn't perfect. We typically start prophylaxis by around 1 year of age. However, for patients with hemophilia A, due to the availability of emicizumab, we start it earlier and earlier. I think the earliest we've started is like 3 days of life. There's this not insignificant rate of intracranial hemorrhage in the first year of life. So if we can prevent that with emicizumab, we can. And then you can certainly see bleeding events happen prior to initiation of prophylaxis. So I think about a patient I take care of who's now like 10, but when he was like 6 months old, his parents kept him in a baby carrier that was like a front carrier, and he was kind of like, his hips were like out, and then he like developed a hip bleed due to like being in the baby carrier. And so that was like at 6 months of age. And so things happen before this time. So we see this occur. And then prophylaxis is standard for severe, but not mild or moderate, although we try to get it done in moderate a lot. And so then it can be difficult to get insurance approval to start prophylaxis in non-severe hemophilia. So for our moderates who are like 4%. Sometimes that can be a really hard negotiation, or mild with 6%. And then this is hard stuff. This is like your whole life that you have to do this. And so that certainly results in some fatigue. We certainly see some drop off of prophylaxis use in the teen years, and then oftentimes in the young adulthood. I think these patients have done this therapy their whole entire life. And so, I don't know, I'd want a break at some point. These medications, as I said, are really costly, and so insurance is really a must. And so if somebody is in between jobs and doesn't have access to insurance, that could be hard. We always work hard to get people signed up for state insurance if we can. And then for patients with hemophilia, things like the Affordable Care Act were really important, because prior to the Affordable Care Act, there was a lifetime cap on your costs. And so patients with hemophilia would burn through their lifetime cap within 1 or 2 years. And so the Affordable Care Act was a huge thing for these patients. And then veins can become difficult to access if somebody's on IV infusions. And so I always patients are always like, they have like names for their veins, like the favorite ones. And we're like, okay, you got to switch it up because that one's going to get tired. For some people, options that are available don't provide the best efficacy. So emicizumab is not effective in the same way for every person. And we think that might be related to variability in individual variability and levels of activated factor IX. And then, as we talked about, timing of infusions with activity can be difficult. So you maybe think that this activity is not going to be that big of a deal, but you know, you're out hiking and all of a sudden you have to like scramble when you didn't think you were going to have to. And then trauma happens, as you all are well aware. No prophylactic regimen keeps a patient in the normal range for factor levels all the time. And so things happen that we can't predict. And then importantly, prophylactic therapy is generally not available across the world. So we're really fortunate here to have access to these medications, but that is not true for much of the world. So when bleeding happens, we use on-demand treatment. And we immediately, as fast as we can, correct to 100%. So if somebody calls, they think they're bleeding, or they're at home, they think they're bleeding, we encourage people to get that factor in as fast as possible. For muscle bleeds, this often requires a much longer duration of factor administration than a nosebleed or even a joint bleed. And then we often will have them infused daily for 3 to 5 days, and then every other days for 3 to 5 more days. So like a pretty long infusion, and then even longer for things like iliopsoas bleeds. And then for hemarthroses, most will resolve within 1 to 3 doses of factor given every 12 to 24 hours. But more prolonged dosing may be needed depending upon severity or history of bleeding, and whether or not they have like a target joint where they've had recurrent bleeding in one joint, and then what are their activity plans. So we'll talk a little bit about hemarthrosis. This likely very familiar to all of you, but joint bleeding can lead to hemophilic arthropathy. And this can either be due to recurrent bleeding, but it can certainly happen with even just one bleeding event. So that's why we work really hard to prevent even that one bleeding event. And the bleeding results in synovial inflammation, cartilage degeneration, and bone damage. So a lot of words on the next slide, but we'll get through it. So just diagram on the left, and then we'll go through some words here. So you can get synovial inflammation. The synovium can't keep up with uncontrolled or recurrent bleeding. So those synovial cells are supposed to absorb that blood, but then they just can't keep up with it. And so you get iron accumulation, and that causes synovial hemosiderin deposition. That then results in inflammation, and then there's increased oxygen demand. You get VEGF release, and you get neoangiogenesis. So you have all these new blood vessels, and then those are prone to bleeding because they're just not as well formed. And then the thickened synovium is also more susceptible to mechanical damage. And then cartilage degeneration can happen. You have macrophages and fibroblasts, like mesenchymal cells that release I can't say that word very well, so we'll just move over. It dissolves collagen. And then you have lots of pro-inflammatory cytokines that are destroying cartilage. And then blood is also directly harmful to cartilage, and you get apoptosis. I always think about I don't know if you've never had a nosebleed, this doesn't really work for you, but if you're a person who gets lots of nosebleeds and you've ever you swallow the blood and then you're oh, my stomach kind of hurts, I don't feel very good. Blood is supposed to stay in your blood vessels, and when it gets out, it's really irritating. And it's supposed to be, right? So it's supposed to send these signals to your body hey, something's wrong, I'm bleeding somewhere, but that can then cause damage. So blood is really supposed to stay inside. And then we can see bone damage due to increased expression of rank and rank L, and then decreased expression of OPG, which favors osteoclastic differentiation. And then interestingly, so thrombin results in proliferation of osteoblasts. And so if you're not getting as much thrombin burst from, because you don't have factor VIII around, then you have decreased proliferation of osteoblasts. And so that can result in an imbalance of your bone formation. And you can see cyst formation, subchondral sclerosis, osteophyte formation, and epiphyseal enlargement. So lots of things can happen even with just one joint bleed. Everybody always asks about, should we tap this joint when they come in for a bleed? And I would say not usually. So if somebody has a really tense, painful joint and it's not improving after 1 or 2 doses of factor, that's when we might consider arthrocentesis. Certainly we need to do this under factor coverage. I've been here since 2010, and I can think of like 2 cases where we've done a arthrocentesis for somebody with a hemophilia related joint bleed. So very rarely do we end up needing to do this, but symptoms really resolve with factor. And then we rarely use imaging other than a point of care ultrasound, which is becoming a more common thing in hemophilia care. With all of the bleeds, yeah.
Hematology do the arthrocentesis, or would we get consulted?
You'd get consulted, yeah. We tried to hire this hematologist who was like, who had done that at her prior institution, and then she ended up not being able to come, but yeah, we'd call you.
We're happy to do it, but
Yeah.
actually, this is really good to hear.
Yeah.
What I hear here is like, this is not us listening to the ER or medicine. This is basically like, we need to talk to you and ortho. That's the conversation.
Yeah. Like there was a patient in Central Oregon who went to the ER and with a joint bleed, and I don't know how it happened, but they got their knee tapped, and I had a little heart attack because they like did not get appropriate factor, and it took a long time for him to recover. And I was like, oh, and I actually think like they didn't get much blood out, and I actually think he had a quad bleed and not a knee bleed. And so it is like, these are like, please call, like this is as exactly what he said, heme ortho conversation. Yeah.
We love that.
Yeah.
How often are these patients, like, if they do have arthrosis, are they coming in and being admitted to the hospital during this, or this is like something?
Yeah, this is mostly outpatient. Very rarely do they need to come to the inpatient unit. Again, those patients with inhibitors might be the time where we might end up needing to admit, but because they can usually administer factor themselves, like we can usually manage this outpatient. And I was going to say, like rarely even, like sometimes they'll come to the emergency room if like, it's after hours, or they for some reason can't get IV access on their own. But we really try to also keep people out of the emergency room, because then things happen that we don't have complete control over, with best intentions always, of course. We always will start with resting in ice and compression. We have our physical therapists are amazing, and have one of them, Nancy Durbin, has been here for a very long time and has lots of experience with hemophilia. And then Greg has not been here as long, but he's also amazing. And they will come up with a great rehab plan for these patients. We have access to crutches and walkers and whatever we need, and we can ship them to the patients. We have cryo cuffs that we'll ship. We have like anything that they need, and we'll get them to them as soon as we can. And then always coming back to, was there anything that we can mediate that was causative? So, are they not taking their prophylaxis? Are they struggling to take it for some reason? Did they start a new sport that they didn't tell us about, and they need some help with like improving their like stamina before they get out into the sport or something like that? Just a quick word about fractures. So the recommendation from the various guidelines, this is from the World Federation of Hemophilia, but it's also true in a few other guidance, that we tend to give at least 2 weeks of factor with any fracture, thinking about how factor, especially for factor VIII, might mediate bone health. And so we will immediately correct to 100%, and then less like frequent infusions for the next 2 weeks or so. And then we avoid full circumferential casts if we can, so we can make sure there's no compartment syndrome. There's this old paper from like 1972 or so that was written by Larry Wolf, who was a peds hematologist here, who just retired like last year and he's like 87 years old. And it like is the one guidance where they're like, you should treat for 2 weeks, and we don't have anything new or different. So this is what we generally will do. Just then a quick word before I go into some other cases about gene therapy, just because I felt like we should mention it. There are 2 products FDA approved for hemophilia B, Hemgenix and Becfez, and then 1 product for hemophilia A, which is Roctavian. These are approved for adults only with hemophilia. There's generally been a slow uptake in the community because we have such good access to factor products. And I think there's been maybe like 3 or 4 infusions across the country. And I'm not going to go through all this, but just to point out a couple of things. So for the different factor levels, for factor 8 Roctavian, they estimate that at 5 years after your infusion, your factor 8 levels would be about 5.7%. So getting you into the barely mild range. And then same for Becfez for Hem B, that your levels would be about 5%. But for Hemgenix at 3 years, their levels were 38%. So some variability across these. And then wanted to point out though that we use the annualized bleeding rate or ABR, and definitely that decreased across all the studies for these drugs. Most of these patients were either using like limited prophylaxis or not a ton of prophylaxis, so it's a little bit of a skewed population, but definitely see some improvement. But it's hard to know who's the right patient. So it provides a functional cure for some patients, but not everybody gets a full response. And it may significantly alleviate the burden for some patients, but durability is really uncertain and retreatment is not possible at this time. So this is a once in a lifetime treatment at this time because people develop antibodies to the vector for gene therapy. And so if you get a response, great. If you don't, that's really sad. So we have lots of upfront discussion about these therapies. And this was really important to have these discussions with people these patients trust. Yeah.
Is CRISPR-Cas9 now?
It's not. It's an AAV vector gene therapy. So they insert the gene into the AAV virus, and then that gets infused as a one-time, and then has hepatic tropism, and then just inserts into the hepatocytes, and then you generate factor 8 or 9. Yeah. There is a CRISPR-Cas9 that's in development, but it's in early clinical trials, but not fully out yet. This is like it's like become like a really hot topic, but it just hasn't seen that much uptake. We're ready to infuse whenever somebody presents themselves. And all the hemophilia treatment centers are kind of separated into different regions in the country. And our region is the mountain state. So we go like Alaska to Arizona, basically. Seattle can infuse for gene therapy, and we can, but nobody else in our region can. So it might be that we end up seeing somebody from our region, like from Arizona or Utah or something, come up to us. And it's unlikely that those places will ever be able to infuse, just to due to a variety of things. Okay, so surgical planning. Got a few more minutes. So surgeries happen all the time. I feel like this is how we spend a lot of our days. This and like dental work is like the most thing we plan. So at least usually we love to have at least a 2-week lead time to create a plan. That doesn't always work, and we can make it work if we don't have that time. But that allows us to ensure patient has factor, and then if they don't have factor, get insurance off to get them factor. And then make sure we get any labs that we might need, such as an inhibitor check or CBC, ferritin, and then make our IV access plan. If they're going to need like daily infusions for 2 weeks, sometimes a PICC line is needed or something like that, because that can like be really difficult to continue. If there's somebody who doesn't infuse regularly, is home infusion an option? What are we going to do? And then we'll make a plan about pre-op, post-op factor. We will give a pre-op dose always. So if you're ever like taking somebody to the OR and they have a bleeding disorder, they should have had their pre-op dose of factor 30 to 60 minutes prior to incision. These medications have a really quick onset, and so we just like to get them in right before you guys start. And then our post-op factor might be a continuous infusion or might be intermittent dosing, depending upon the type of surgery we're dealing with. And then inpatient admission may be needed for factor administration or monitoring, depending upon the surgery. And then we have also, just in case their patient doesn't tell us or we don't get notified, we have an EPIC alert set up for anybody with a bleeding disorder diagnosis in their chart. If they get scheduled in any OR at OHSU, it sends our team an alert so we can be like, hey, don't forget this patient has a bleeding disorder. And so every once in a while, we'll find patients that are not patients of this center that are scheduled for surgery. And then we will work to insert ourselves to make sure that they get what they need to have surgery. Things that are helpful for us to know, these might seem silly, but like was thinking about what is, like when I'm making a surgical plan, what's really helpful to know? What's the bleeding risk? I don't always know what, like if you're gonna do X, Y, or Z surgery, do most people bleed? Do not anybody bleed? And when is the bleeding risk? So is it like, are we most concerned about intra-op bleeding or post-op bleeding, or where is that gonna be? And that helps us think about our timing and duration of factor administration. And then I always think, what happens if they bleed? Is this gonna be like, they're never gonna have a good outcome, or I'm gonna see it right away? Is it gonna be like really their joint's gonna be big, red and swollen? What's gonna happen? Are there drains involved, and when do they come out? So what are we gonna be looking for there? What's their anesthesia? Is there a nerve block? Do I need to plan for that? Is venous thromboembolism prophylaxis needed or standard? And if it is, then there's certainly guidance for hemophilia and VT prophylaxis, so we can work through that. What's the recovery time, and like how long do you expect them to be out for? How long will they be immobilized? Sometimes that helps us think about factor too. I think as patients get older, it's like balancing their thrombosis risk with their bleeding risk. And then when does rehab start? Because oftentimes we'll do more factor prophylaxis around the time that they start moving, just to really make sure that they're like well covered. And then what's going on in there? So I always think about, like, this happens a lot with dental procedures. They have like a whole nother language. They're like tooth number, whatever. I'm like, I don't even know what tooth that is. And so just the more information we get about the surgery, the better it is. And then it also really helps our physical therapists because they're going to start working for an ortho surgery, especially a rehab plan for the patient. And then there's only, as I said, about 1,800 patients that we see with bleeding and clotting disorders. And that's all comers. There's like smaller amount of like severe and moderate that are going to be more frequent kind of users of the healthcare system. And we know most of these people and have really good relationships with them. And so the PTs especially will start to help the patient think about, all right, you're going to have this surgery. Here's what you're going to have to anticipate. And they just have a really good relationship with them and can help them understand what's going on. For some procedures, their local hospital or surgical center may be a reasonable option, and we will do our best to keep people in their community. But for other things, we recommend that they be done at OHSU. And the reasons for that might be we have reliable access to factor and can easily get more if there's unexpected bleeding. So if somebody's in even like Medford, they have very limited factor doses. And so just trying to think about if somebody has unexpected bleeding, what are we going to do? And then we have reliable laboratory testing. So we have in-house factor levels and availability of stat labs, where most other places will send out their factor levels, and it can take days to get results. And then we're here available to help for management of unexpected bleeding. And then our PTs are here as well. And then I would say, in addition to those people on our team, like our social workers are here, our like nurses that know how to coordinate some of these outpatient things are here. So sometimes it's just like, this is a major surgery. This really needs to happen here at OHSU. And we always feel bad making people come up here, but it ends up often being the safest option. Okay, so I'm just going to go through a couple cases in the last couple minutes. So this is a really common PED scenario. So 16-year-old severe hemophilia B on Alprolix, which is an extended half-life factor 9 product, for his prophylaxis, was playing in a soccer tournament all day Saturday. His left ankle felt sore Saturday night, and on Sunday morning he had left ankle swelling and pain. Decided it was probably fine because he really wanted to play in his game on Monday and didn't want to tell his parents, and they would say no. But Monday morning wakes up and couldn't wear bait and decided it was time to tell his parents. So infused a dose of factor 9 and they called the HTC. And what we would do in this circumstance is, if they want to and it's not improving, or they want to be seen, we'll see them same day. Or if the next day they call and it's not improving, we'll say we'll see you there. And usually one of the hematologists or the nurse practitioner and then a nurse and the PT will see them. The PT might do a point of care ultrasound and will identify, in this case, a left ankle hemarthrosis. And then we'll infuse a couple more days, rice. And then the PTs will make a plan with the patient to help get them back to their sports. And then probably have an ongoing discussion regarding their prophylaxis and level of play, and should we switch around their infusion days. This is his second ankle bleed this soccer season. He's also had bleeds in the same ankle when he was younger and was not getting prophylaxis reliably. And then he typically reports that his ankle is intermittently swollen, painful, and affecting his sport activities. And an ankle x-ray is done a while after his acute bleed, and it shows some moderate to severe joint space narrowing with early degenerative changes. So this is sometimes where we have a question of like, is it time now to refer to ortho just to get established? Do we need further imaging at this time? Are there interventions that would be done now? Again, we'll try to manage, like get them on a more regular prophylaxis schedule, change their prophylaxis, what PT can do, things like that. But this is where sometimes it can be helpful to say, okay, why don't you go to see ortho and see if there's anything else that they might recommend, and then have good discussions back and forth. And then I'll talk just about 2 adult cases. And these are, again, are Nancy and Greg. I'm sorry to steal his picture off the website and crop them. But these are our 2 physical therapists who are like all really involved with these adult patients with orthopedic injuries. So very active 74-year-old with mild hemophilia A was seen to establish care after he moved to Oregon. Several months prior to moving, he fell on a hill onto his weed whacker. Oh my God. Found to have a right rotator cuff tear, and then was seen locally and was recommended to have surgery, but they live in Central Oregon. He doesn't know how to self-infuse. They don't carry factor at his local hospital, and they send their factor levels to LabCorp, which is like the worst for these kinds of labs and can take like multiple days to get around. So this might be a patient where we say, oh, it'd probably be best if you saw ortho at OHSU, because if you need surgery, it'd be safer to do at OHSU. And then we would make a plan about IV access, and our team can work on like travel, local hotel accommodations if needed, and family support. And then our HTCs will help make a plan for rehab. And then we like obsessively call these patients after surgery. So we call them at least every day for the first couple of days, make sure they're doing okay. And then every few days after that. So we're like obsessively calling. But this is a case where it might be like, I always feel bad because I'm like, they already saw somebody locally and now we're gonna have to have them see somebody else. But really the best thing is to have them seen here. And then this is a current active case. I don't know if Kylie joined, but Kylie Martins is one of the adult hematologists, and she's been working on this case. So I think he's about 55 with severe hemophilia A and a high titer inhibitor on emicizumab for prophylaxis, and has had frequent breakthrough bleeds and tons of bleeds as a young adult before he got good prophylaxis, and has a 30+ year contracture of his right knee, and he's going to undergo a total knee replacement. And so surgical planning, just the same questions. When is it bleeding likely to occur? Does his like current status of his knee change the bleeding risk assessment? Does he need VTE prophylaxis? Do we have factor on hand? And we do, but do we have enough? So this patient's going to need a ton of factor. This is going to be a potentially really bloody surgery for him because of his inhibitor. So we use factor 7A. Right now, OHSU has 7-FACT and Novo 7, so we can use either. This is a high risk bleeding for this patient. In the studies with 7-FACT, patients still had bleeding with surgical procedures, so really kind of a nail biter surgery. I've been working with Kylie to try to think about what's the optimal thing for this patient. And then for this patient, even though maybe a knee replacement would be outpatient, because of his bleeding risk, we recommend inpatient so we can adapt the plan as needed kind of on the fly. And then really being careful about balancing bleeding and clotting. Factor 7 is dosed every 2 hours, and it's a really prothrombotic medication. And so just really being really careful about this. So lots of opportunities, and I just listed a few, but just identifying patients appropriate for referral, maybe who don't need surgical intervention, but need long-term management or follow-up. And how do we like make sure that we're giving you guys the right information and who's best to refer, and then for like both non-surgical and surgical planning. So in summary, we're the only game in town, and we're really charged by our grant that we have to take care of anyone with a bleeding or clotting disorder, and we have a big team ready to support and do whatever we need to help these patients. Prophylactic therapies can definitely help prevent bleeding, but bleeding still happens and can cause long-term joint damage. And then any person with a bleeding disorder requires planning for surgery, and the more information we have, the better we can plan. So just a quick, this is kind of the change of hemophilia care over time, just thinking about how do we get people to kind of able to do their regular activities and enjoy their life as much as possible. So this is kind of where we are for hemophilia as of today. And with that, I'll stop. Yeah, yeah.
Transfers for us have been challenging for several
Yeah.
different reasons at different time points, but getting people transferred in has been more challenging than it was in the before
Yeah.
times.
Yes.
How has that been for you all?
Similar, yeah. There, like, I can think of a specific case last winter where it was like weather was probably the main factor. And then we like could not get this patient factor, and like our pharmacy team was like, we can make it across the mountains. And I was like, oh, I don't know. That feels really scary. So it can be. And then I think sometimes too, there's, I try to say this without being too like annoying, like annoying myself or and just like, these are very specific patients. And sometimes it's really, we've got to get the right people on the phone call sometimes. And we have like wonderful colleagues who are covering, but maybe aren't as intimately aware of all the resources we might have at the HTC. And so sometimes it's like, oh, I think if they would have called like our clinic, we might have been able to coordinate something different. So, and we have like a lot of like home health people that we work with across the state where we can like get somebody to their house or, like, is there a different thing we could do that could temporize for the next 6 hours, 12 hours, whatever it might be. Or like I've like called and been like, okay, tell me everything you have at your hospital as far as factor, and let me see if I can make something work. Or I do think it can delay care, and it can feel really scary of like what's going on. But I think we can often find okay, for the next 12 hours, we got this, or whatever it might be. Yeah. Sorry. I was just going to say, if it used to be historically that ortho was at hemophilia clinic, we had these like multi-D clinic with ortho because it was just like, if you come to adult clinic, it's very different than peds clinic. The peds kids are like in every sport and they're so active. And a lot of the adults come in and they're stuck like this and they're limping, and it's just a totally different experience. If anybody ever wants to come to hemophilia clinic, anybody's welcome anytime. There's also like, if you're like, we want to do research in hemophilia, we have like a great research team. So if this is like interesting to you, let me know. We're happy to have people.
One more question.
Yeah.
I don't know how much you are aware of the fact that Medicare is trying to control costs, and they are now doing a lot of what we call bundled payments.
Mm-hmm.
And total hip and total knee are ripe for bundled
Yeah.
payments. And I know this because I'm part of the group. The hemophilia patients completely destroy the bundle.
Yeah.
I'm just curious what your clinic's take is on all of that.
That's a really good question. So for outpatient hemophilia medication, it gets billed as part of their medical and not pharmacy benefits. And so I don't know if that too plays into part of this. It's a really good question. I don't know the answer to, but I can ask our like managed care people to look into it too, because I think it probably will become like increasingly common.
I suspect that it's going to be an increasing problem.
Yeah.
That our surgeons will be willing to do the surgery, but then our hospital will balk because
Yeah.
all of those costs they have to eat.
Totally. Yep.
Mostly the factor, as
Yep.
you well know.
Yeah. And like that kind of surgery is probably at least $150,000 worth of factor. So yeah. Yeah. I will I'll ask our managed care team and I can let you know. Yeah.
We already see it just
Yeah.
on the length of stay.
Yeah.
A knee replacement in a moderately healthy person is an outpatient.
Right.
One night stay now, and just for you to even say like, hey, they'll be here for 4 days, and we're suddenly already going.
Ooh. Yeah, totally.
Before we even get to the cost of
Totally. Yeah. 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 And I think it's hard to know too. Sometimes it's like, oh, they sailed through. We're good. You can go home. And I think yeah, that's a really good question. I'll ask our managed care team. Did you have another question? I'm sorry. Okay. Okay. Great. Well, thank you so much for your time and attention. I hope you have a good day.
My question